Dr. Twaseem and welcome to my Derm Classes. So today's lecture is lecture 5 of the Epidemiology series, and I'll be mainly dealing with different types of studies, especially the case reports, case series, cross-sectional study and the cohort study. We'll be seeing different advantages and disadvantages of each of these studies. So let's get started. So as I mentioned, these are the main studies I'll be dealing with today. So first about the case reports and case series. So this type of study is actually a study in which you in detail describe a case. It can be a new symptom, it can be a new disease, it can be a new investigation that you have done, or it can be a new treatment that you have given. So if it becomes a series when there is more than one case, but the peculiarity of this kind of study is that there is no comparison group. So since there is no comparison group, the strength of the study is not very high, which means if you give one treatment to a patient and it randomly works, it doesn't mean that the treatment will work in a different patient. So we need a couple of patients and a comparison group to say that yes, this really works in this particular disease. So mostly this is actually used for a hypothesis generation. For example, you can say, okay, this treatment might work, so it might be worthy that we do a study where you compare with the current treatment, or then you take a couple of patients with a comparison group and see the effectiveness of this particular treatment. Thus, it's basically used for a hypothesis generation. And coming to the ecological study, so the peculiarity of ecological study is that it's done on a population base, which means you are not considering individual patients as a study subjects, rather we are considering the whole population. For example, it might be an association between meat consumption and colon cancer. So if you consider meat consumption in one patient and colon cancer in the same patient, so that is the normal study. But imagine that you are considering a state. For example, you are taking USA and you are looking at the meat consumption, and you see that the meat consumption has gone high in the past few years, and you see a similar trend in colon cancer which has gone up. But we actually don't know if the people who have consumed the meat has actually got colon cancer. So because it's a population level study, and again you can establish an association but not at an individual level. So this is an ecological study. So again the problem is that there can be several factors that has resulted in this outcome. For example, the colon cancer, and as I mentioned, it might not be the same person who has consumed meat that have got colon cancer. So that's one thing. And the second is there can be a lot of confounding factors in this type of study. So it's again useful for a hypothesis generation, but you need better studies to arrive at a proper conclusion. So this is basically an example of an ecological study. So in this particular study, what they have done is that they have analyzed the sunscreen sales and the occurrence of melanoma. So as I mentioned, we are not evaluating if the people who have applied sunscreen has got less occurrence of melanoma. So this is the problem with the ecological study. But as I mentioned, it's actually good for a hypothesis generation. Coming to the cross-sectional studies, as the name suggests, it's a cross-section. At a point of time, you're taking a cross-section and then analyzing the results. So it's like a snapshot where you're assessing the outcome and the exposure and the association at one point of time. Normally what happens is that we are able to analyze the prevalence, because we don't know if the cases that exist are the new ones or the old ones. Since we are only considering a particular snapshot, so we can only calculate prevalence from a cross-sectional study and not incidence. We also can't estimate the temporal relationship because we are only considering one point of time. And if the exposure is constant, like in the case of race or gender, then it's fine. But otherwise, cross-sectional studies are not the very best ones. So in this particular study, what they've done is that they've set out to analyze the occurrence of dermatological diseases in differently abled children. So they have taken just single time frame, and then they have assessed the skin diseases. So they're not analyzing if the differently abled children has got skin disease before. For example, if they got a handicap at a particular point of time, and whether they had the skin disease before or after. They're only analyzing at a particular point of time, at a snapshot, what are the skin diseases that's occurring. So let's consider the problems of a cross-sectional study. So imagine that you're set out to determine the coronary heart disease among the farmers. So you can see that in a cross-sectional study, maybe there is less prevalence among the farmers. But the thing is, as you know, the prevalence is incidence into time duration. So we don't know if it's because the incidence is less. We don't know if it's because of less time duration. We don't know if after the disease they have decreased their physical activity and thereby reduce the coronary heart disease. So it's actually very difficult to determine in a cross-section studies. So this is the problem of cross-section study. Coming to the cohort studies, follow-up studies, or the long studies. So the cohort studies are basically a study where you enroll patients based on exposure, for example smokers and non-smokers, and then you follow the patient forward and see if the patient has developed the disease. It might be a case where the thing has already occurred and then you're following up. So that's called retrospective cohort study, which will be dealt later on. The thing that you need to understand is the cohort studies are basically enrolled based on exposure, for example smoking or not. But the case control studies are enrolled based on disease, for example presence or absence of disease. So this is what you need to look for. Are the patients enrolled based on exposure, or are the patients enrolled based on the disease? So this gives you an idea of it's a cohort study or it's a case control study. So this is a picture of basic cohort study where you have certain subjects and then you're following them forward to see for the development of the disease. So this is an ideal scenario where you have 20 subjects and you were able to follow up all the 20 subjects at the end of 1 year and see if they have developed the disease or not. So the key features is the selection of subjects is based on exposure status, which is presence of exposure or absence of exposure, and the participants hasn't developed the disease, but we are looking for the development of the disease. So the participants should be at risk of developing the outcome. For example, you cannot assess uterine cancers in men, right? So they should be at risk, and then we are looking for the outcome. So the exposure can be present or absent. It can be based on severity, it can be based on duration, or it can be certain time varying exposures as well. So these are all different possibilities for the exposure in a cohort study. Now what's the role of unexposed? It basically gives a counterfactual outcome, in the sense, what if the subjects who smoked didn't smoke? So that's what we are looking for in the unexposed population. So in an ideal scenario, we are supposed to go back with a time machine and see what if they didn't smoke, how would the outcome be. That's actually not possible in a real life scenario, which is why we are actually taking the control groups. So as much as possible, the control group should reflect the cases the exposed group except for the exposure, and then you're actually looking for the outcomes. So we should be able to follow and detect the outcomes as well in such cases. So let's take a look at what are the different types of cohort studies. So you have open and closed cohort study, which is based on enrollment of subjects. We'll deal in detail, and then based on time we have prospective and retrospective cohort study. Let's see. So coming to what's an open cohort study. So open cohort study is a situation where the population is actually changing, which means the subjects can come and go. So this, for example, you can think about that if my cases are residents of a particular place, they can enter and leave at any situation. In the sense, there can be new people coming in, there can be old people who are going out. So, and as well as they'll be lost to follow up and competing risk, which means you can, lose the people to or the subjects to follow up, and there might be a situation where they are no more at risk of developing the disease. So that is a competing risk. So the exposure status can also change. The outcome measure would be the incidence rate. So whenever you have this loss to follow up, you can no more take the whole time that the person has contributed, because the patient has left in between. So at that particular point of time, what you do is that you consider the time that particular patient has contributed to the study. So that's called as a person time. And if you have a person time, then the outcome measure would be incidence rate, which means it's based on time, and the measure of association would be a rate ratio. So this is what you need to know. So you need to measure the outcome, and then you need to do the measure of association. So what's a closed cohort? So this is a fixed population where you have fixed people from the beginning, and you don't have a varying subjects. So and the outcome measure would be cumulative incidence, which means it's number of new cases that has occurred divided by the total number of cases. And you can also consider incidence rate, because you can probably consider the whole time the patient has been in the study and then calculate an incidence rate. Now, what's a fixed cohort? It's actually equal to a closed cohort, but the only thing is you might lose the people to follow up, or you can have a competing risk. Actually, this happens in most of the scenarios, because not all the time you can have all the patients that you have set out to study, right? At some point you might lose the patients, or they might die, so that they are no more at risk of developing the outcome. So that is competing risk. So again, here the patients or the time that they contribute is varying. So in that case, we actually measure incidence rate, and the measure of association would be rate ratio. So this is again example of two cohorts. Now I'll be more clear for you. So you see the closed cohort where you have a fixed cases from the beginning till the end, and you have certain occurrence of the disease. In an open cohort, as you can see, the patients come and go. There are also loss to follow-up and competing risk. Coming to the fixed cohort, as we have mentioned before, at the beginning they're all there, but in between there is loss to follow-up, competing risk, and there are also people who develop the disease. So that is fixed cohort. So I hope this is clear. What's a closed cohort, what's a fixed cohort, and what's an open cohort. So what's a prospective study? So here the follow-up period is yet to come. After you start the investigation comes the follow-up period. So that's a prospective study where the outcome has not occurred yet. So an example would be a prospective study of psoriatic arthritis with psoriatic patients. So you take all the psoriasis patients and then you follow them up and see the development of psoriatic arthritis. Coming to the retrospective study, so what's the retrospective study? Which means the occurrence of disease is already occurred. You are going back in time and then moving forward in time to see for the outcome. For example, imagine that you already have a registry where you have the psoriasis patients and the occurrence of psoriatic arthritis probably after 10 years, 20 years. Now you're taking a registry and then you're doing a retrospective cohort study where you are enrolling patients based on if they have psoriasis or not, and then you're moving forward in time and looking if they develop psoriatic arthritis. So that's a retrospective study. So again, this is an example for retrospective cohort study where they have analyzed the autoimmune disease in dermatomyositis patients. Coming towards an ambidirectional cohort study, which means it has both retrospective and prospective cohort. So what happens is you start the study, go back in time and start the study, but there are things that's yet to occur. So it has also a prospective aspect. So when these both are combined, it becomes an ambidirectional cohort study. So what are the different measures of association? So as I've already mentioned, if you have all the data, then probably you can look for the absolute, as the relative risk. So relative risk, the risk difference or the odds ratio. And if there is only person time contribution, which means there is loss to follow up or competing risk, then probably it's an incidence rate ratio and incidence rate difference. So these are different measures of association that you calculate in a cohort study. So in a particular study, you need to know what is an outcome. What outcome, for example, psoriatic arthritis, how are you going to measure psoriatic arthritis? So that's the outcome measure. Probably it's a proportion number of psoriatic arthritis developed in comparison to the whole population. And then you have the measure of association. So the measure of association depends upon what kind of study you're doing. If you're following up, like if it's a cohort study where you have a temporal association, that is a situation where you can really determine the relative risk. So otherwise, for example, in a case control study, you don't have that temporal relationship, right? So in that particular case, the measure of association would be odds ratio. So there are two different types of measures of association. It can be absolute or relative. Absolute means absolute. For example, the difference. 10 is the risk in one case and 5 is the risk in the other case. 10 minus 5, 5 would be the absolute risk difference. Whereas relative ratios would be like 10 by 5, which is 2. So there's a difference between absolute and relative risk ratio. So you have rate ratio, you have risk ratio, you have odds ratio. All these are called as relative risk. Now, so as I mentioned, there can be loss to follow up in a fixed cohort or an open cohort. So in that case, you are determining incidence rate ratio or incidence rate difference. So if you could sit down and just jot them down and have a look, it will be very clear for you what are the different measures of association in different studies. Coming to what are the different possibilities for bias in a cohort study. So selection bias happens when you select the study subjects. So when you select the participants purely based on exposure, that's fine in a cohort study. But with some reason, it becomes related to the outcome of the disease, that's a selection bias. There can be loss to follow up, can be a selection bias. Why? Because while they are taken into the analysis, you have lost some people or the subjects. So that's a selection bias, which is, it can be non-informative censoring or informative censoring. Non-informative censoring, so I'm just giving you the etymological terms so that you can go back and refer more about it. Non-informative censoring is where there is no difference between two groups. For example, both in the exposed and the non-exposed, you lose equal number of people, so that's a non-informative censoring. If you lose more people in the exposed, then that's an informative censoring. Coming to the information bias. Information bias is a bias that occurs while you collect the information. So it most likely happens is misclassification. Misclassification is you classify wrong. So it can be differential or non-differential. So non-differential misclassification is where you misclassify in both the groups equally. But differential misclassification is where you, as the name suggests, it's differential. So you misclassify in one group and not the other. And confounding is something that we have already dealt in one of the lecture. If you have not watched this, you can just go back and have a look at that. That can also occur in a cohort study. And coming to what are the strengths of the cohort study, the thing is that we have a temporal relationship there. So we know the outcome has occurred after the exposure. You can look for multiple outcomes. You can look for rare exposures, because in a case control it will be difficult to find that particular exposure in all cases. And you can also directly measure the disease occurrence and the measure of association as well. So what are the limitations? It's actually quite time consuming. It requires a lot of money. It's difficult in case of rare outcomes, and also the validity can be affected by loss to follow. Why? Because there occurs a bias. So these are the limitations. So these are my references. Most of these is from the lecture which I've been taught. So I hope everyone has got some information about what these different studies are. So this is just an overview. Feel free to go back and check more about each different words which I've mentioned if you want to dive deep into it. So this is just an overview of all the topics that we have set at the beginning. So thank you so much. I hope this helped, and see you soon.